Hi, I'm Connor Price, and I'm a PhD student in the School of Computing at the University of Portsmouth. My research topic is detecting patient deterioration, evaluation of the National Early Warning Score 2 in different patient groups. So first of all, what is the National Early Warning Score? It's a score that is used in all NHS trusts within the UK in order to evaluate patient deterioration on wards. So if you're a patient who's unwell, the clinical staff need to know if you're improving, you're getting better, or you're deteriorating, you're getting worse. If you're getting worse, they need to know to what extent you're getting worse. Do you need to be monitored more closely? Does a doctor need to take a look at you? Do you need intensive care? So, how does it work? NEWS uses vital sign measurements regularly recorded by clinical staff to establish how unwell a patient is. These vital signs include things like blood pressure, heart rate, and respiration rate. There are normal ranges for each of these measurements that healthy adults will fall within, and NEWS helps us to determine how far from the normal ranges a patient's measurements are. The further from normal the patient's measurements are, the higher the risk of a patient deteriorating. NEWS also deals escalation procedures to ensure that a patient is being appropriately cared for, depending on how high the deterioration risk is for that patient. This is the NEWS2 chart. This is what's used to calculate a NEWS score for the patient. You can see there are 7 physiological parameters that are monitored down the left hand side. These are respiration rate, oxygen saturation of the blood, if a patient requires supplemental oxygen to assist in the breathing, systolic blood pressure, pulse rate, consciousness, and temperature. You can see oxygen saturation of the blood has 2 separate scales, and we'll talk about why in a little while. The white center column shows the normal range for each vital sign. As we expand out from the center, the further we get, the further the vital measurement is from the norm, and the higher the score allocated. Let's give an example. On the left, we've got measurements recorded of a patient's vital signs, and we're going to figure out what that patient's NEWS score is. We'll start with the respiration rate. We know that the patient is taking 21 breaths per minute, so we're going to have a look on the chart, see where that is. So we can see on the chart that that measurement is associated with a score of 2 because it's a bit above the normal range. So we can highlight that, and then we're going to record a score of 2 for that vital sign. We can go down the list, and we can do the same thing for all of the other vital signs until we've got a score for every measurement. It doesn't matter if the measurement is higher than the normal range or lower than the normal range. All that matters is that it deviates from the normal range, and so a score is associated with that. Once we have a score for each vital sign, to calculate the NEWS value for that patient's observation, we take all of the scores and we add them together. So this patient has a total NEWS score of 5. So once they've got the score, the clinician has to evaluate whether a patient's care needs to change. This clinical response guidance deals what needs to happen in the event of a patient reaching a specified NEWS score. The actions usually involve monitoring frequency, informing other staff members, transfer of care to more specialised staff and departments. The clinical response varies, as NEWS is not a diagnostic tool. It's intended to alert clinicians to deterioration so they can decide upon the best course of action for a patient. The example patient we looked at in the previous slide reached the urgent response threshold, so needs to be monitored more regularly, and an urgent assessment of the patient should be performed. So what's my research? I mentioned earlier that there were 2 scales for oxygen saturation, SpO2. The second scale was introduced for use in patients with hypercapnic respiratory failure. For these patients, the recommended oxygen saturation range is 88 to 92%, as you can see in the normal range on that chart. If they get higher levels of oxygen, this can cause serious life-threatening problems. By the normal NEWS scale, they would be given a high NEWS score when their blood oxygen level was in the expected range, so this modification was introduced. This meant that these patients wouldn't be given an artificially high NEWS score when their condition was being managed and oxygen ranges were to be expected. So following this, there's the potential that other patients with specific illnesses might have different ranges that for them are normal for each of the vital signs. They might be getting scores within the scoring system that don't accurately reflect their level of deterioration because having their specific condition alters what the normal is for them. Their physiology changes in such a way that it would cause alarm in your average patient, but for them, this is just part of their condition. My research is to determine if NEWS is the best score available to be used in patients with a variety of conditions to ensure that patients aren't being underserved through use of a standardized early warning score. This follows recommendations from the Healthcare Safety Investigation Branch in 2019, which recommended that NEWS2 performance should be evaluated in a variety of different patient groups to determine that the score performs well for patients with various conditions. In this project, I worked in collaboration with Portsmouth Hospital University NHS Trust, and we have a fairly large data source collected between 2010 and 2018 that we used to undertake this research. One of the difficulties of this research is that there was a lot of conditions a patient can have when they come into a hospital. As you can see, there are 10,735 unique diagnostic codes within this data, and each of these represents a different condition a patient can have. There aren't necessarily enough patients with each diagnosis to analyse every condition individually, so patients needed to be grouped based on those who have medically similar conditions. So we ended up with 123 different groups of patients to analyse. I found 37 published early warning scoring systems, which can be used to evaluate patient deterioration. These broadly use the same physiological parameters as NEWS, although some use fewer parameters, and they all have different ranges for normal and abnormal measurements for each of these parameters. As with the majority of studies involving large quantities of data, exclusions were required. Things were excluded for multiple reasons. First, we needed to exclude any patient groups that didn't have sufficient numbers of patients for analysis. This could be due to the conditions that the patients had being uncommon, or that Queen Alexandra Hospital doesn't specialise in the conditions and the patients go up to other hospitals for treatment. Admissions that are maternity or paediatric specialty had to be excluded, as the required patient monitoring software hadn't been implemented in the relevant maternity wards, and alternative early warning scores are used in paediatric patients, as these patients have different physiology to adults. Observations were excluded when the full complement of vital sign measurements had not been recorded, as a new score couldn't be calculated. To the right, I've noted down some key terms. Rock curve analysis was what we used to evaluate the performance of early warning scores. Discrimination was the primary metric used to determine the best early warning score. Scores that can better distinguish between patients who are at risk of death within 24 hours are more effective at warning of impending deterioration. I'd be remiss not to highlight the major limitation of this study, being that it only includes data from a single centre. But ideally, we would replicate this study upon another patient population from a different location, as the results of this study could theoretically only apply to the Portsmouth area. There is difficulty in performing a multi-centre study of this scale. Differences in recording and monitoring practices within different hospitals, as well as software limitations and data extraction costs, all play a part. However, due to the wealth of data available from Portsmouth Hospital, this study can still provide significant insights into early warning score performance in different patient groups. The graph on the right is an example of a rock curve, which graphically displays the performance of each of the early warning scores within the group of patients with hypertension-related diagnoses in this example. The solid black line represents NEWS performance, while the various coloured dashed lines represent that of the other early warning scores. NEWS was among the top performers within this group, being both sensitive and identifying the majority of patients who would die within 24 hours, while also being specific in that it minimised the number of patients that it incorrectly identified as at risk of death within 24 hours. This is important, as incorrect identification of deteriorating patients increases workload for clinical staff and can cause alarm fatigue. The results of this study didn't identify any of the 123 evaluated diagnostic groups as being underserved through use of NEWS, as opposed to another published early warning score. NEWS was either the top performer or performed the same as other early warning scores within each of the diagnostic groups, and so there was no evidence that use of a different early warning score would benefit any of the patient groups analysed. Thank you very much for listening. I hope you've enjoyed it. I hope it's been informative. If you've got any questions, you're more than welcome to send us an email at the email address on the screen.